activations.
Good afternoon, everyone. Thank you, Dr. Kumar, for having me to be a part of your course. Today, I will be discussing about inadequate capsular support. And an inadequate capsular support is a challenge for any cataract surgeon for the lens placement. So this is a patient who came to us with a dislocated posterior chamber lens, which is a single-piece lens. A thorough vitrectomy has been done, and the lens has been brought into the anterior chamber. This being a single-piece lens cannot be used for refixation, and hence has been explanted out of the scleral tunnel. So we had to plan a second technique where we needed to do a secondary IOL, and a Yamane's technique has been planned, which is...
Can't see.
Yamane's technique was planned, which is a relatively newer technique, a very elegant technique described by Dr. Yamane in 2016, which is a transconjunctival intrascleral haptic fixation where we need to have no flaps or glue. So, so we just want to show the marking. So this is a normal eye where I wanted to describe the marking because this is a very important step of the procedure. We mark the 0 and the 180 for a well-centered lens. Take 2 millimeters on and mark behind the limbus, and another mark up, one on the upside and the one on the downside. Now the reason for doing this is because you're going to be doing lamellar scleral dissection. What's important in this is that the length of your scleral tunnel should be equal on both sides so that your lens gets well placed, and also it should enter exactly the 0 and the 180 degrees. So coming back to the case, so we bent the 26 number needle at the hub, and the ideal needle to use would be a 27 or a 30 gauge thin wall needle. Both these needles are a little difficult to procure, so I used a 26 number needle in this case. Coming back to the case, you do the limbal markings at the 0 and the 180 degrees, and you mark 2 millimeters behind the limbus. Once we do that, you use a 3-piece, I've used an Alcon lens, but you are also good ahead to go ahead and use a sensor lens. And the scleral dissection is done with a 26 number gauge needle and entered into the eye at the 180 mark. The leading haptic is grasped with your forceps and is threaded into the lumen of the 26 number needle. Once the threading of the 26 number needle is done, the needle is withdrawn back such that the haptic is externalized. Now the challenge that I faced here while doing this technique was that my trailing haptic got entangled in the tissues over there, and so I had one haptic which is externalized and the other haptic has been entangled. So I'm trying to remove it from the tangle, and while doing this what I realized is that my lens is flipping. I did not want to cause too much traction on the optic-haptic junction, least I might tend to lose it. So trying to get the lens back in orientation, it looked difficult. We went ahead and did the cauterization of the haptic tip to make it bulbous. So this was the first time that I was doing the case, and I didn't realize that a bipolar cautery would not work as well. The heat cautery works better. We did get away in this case where we managed to get the tip bulbous and make a flange, but heat cauteries definitely do a better job where you just need to put it a little away from the area. Once we have done this, we went back ahead inside the eye, and this was again the challenge that I had to do is reorient the lens in its right direction. So I had to flip the lens over. Once the lens has been flipped over, we held the haptic tip into the vitreous cavity and the haptic tip that was externalized and caused the rotation of the lens, reoriented the haptic in its direction back and brought it above the anterior, in the anterior chamber above the iris. So we've not lost the lens. Now the reason of what I wanted to show here is that we've not lost the lens into the vitreous cavity because the tip has become bulbous, so it doesn't slip back into the vitreous cavity. Your chances of losing the lens is very minimal. This is the single most difficult step in the whole procedure because the angulation needs to be right. So when we try to trail the superior haptic into the lumen of the needle, your angulation needs to be right. So this takes a little bit of maneuvering. And just when we were doing the maneuvering, the fluid in the irrigation bottle got over, so hypotony obscured the view. Changing the fluid bottle also brought in air. So these were the challenges that you're really facing at one of our difficult steps. We came out of the tunnel, got the air bubble off, re-went in, grasped the haptic, and got the angulation right, but the haptic broke at the tip. So we got that bit done. Since we'd got the angulation, I didn't want to give up at this step. Threaded the needle through the lumen and externalized the haptic. So the take-home message here is that the Alcon 3-piece is a thin lens. A sensor does better in these cases. Now, Dr. Yamane has described lenses or has used lenses like the Zeiss, which is the Lucia Zeiss, which has the PDVF material to it and is a better lens, but we do not have the availability of the lens globally. And hence we had to use what was available to us. So the 3-piece Alcon is what I use, but sensor is a better lens. So we went in again looking for that piece of the haptic, because you can't leave it there. It might drop into the vitreous cavity, which may cause us another problem. So the haptic piece is recovered back, and all's good that ends well. So we've got a well-centered lens at the end of the procedure. We did have variations from Yamane's original technique, where he uses a double needle to bring it out. This is the first day post-op of the patient, and this is the lens centered on dilatation. So he uses his double met and he externalizes both the haptics simultaneously. We have done a sequential externalization. He advises to use the 30-gauge needle, which is a thin wall needle. We don't find the availability so much, so I've used the 26. And also another take home is when you want to cauterize the haptic, it's better to use the heat cautery than the bipolar cautery. The second case that I would describe is a case where the patient came to us with a corneal tear and then developed a traumatic cataract. So came with a full thickness corneal tear. A primary corneal tear suturing was done for this patient as a primary procedure using a 10-0 nylon suture and making sure that all the knots are well buried. 1 month post the surgery, a cataract surgery has been planned, and since he is a young male who had a traumatic cataract, it was done with irrigation and aspiration, and an intraocular lens was implanted. So we used a single piece intraocular lens was implanted into the bag, and this was done as the secondary procedure. So once we implanted the secondary lens was implanted into the eye, and in the bag lens was implanted for the patient. The patient had a post-op result where he had a mydriatic pupil. We gave him 1 month where we went ahead and did the suture removal. And at the end of 1 month, what we realized that the corneal scar is bisecting the pupillary area. Also, the patient has an irregular pupil, and we planned a pupiloplasty. So 2 incisions were made at the distal and the proximal end, and all the additions in the iris were separated from the anterior capsule, making sure that we have the leaflets of the iris which are relatively free so that they can be engulfed. Now at this stage also pulling onto the iris helps because it mobilizes a lot more of iris tissue from the angle. Using a 10-0 Prolene suture with a straight needle, a railroad technique has been done which is passed through the leaflets of the iris. Then through the proximal end, a loop is formed and got out through the distal end of, of your entry. And 4 loops are passed. This is the single pass 4th row pupiloplasty which has been described by Dr. Amar Agarwal. And 4 loops have been passed through the loop. So when you do 3 loops, the knot tends to open up, and when you pass them 5, the knot tends to be very big. So 4 loops is the ideal situation to pass it through, and the edges are then pulled so that the leaflets of the iris are well approximated. The similar procedure will then be considered to be done superiorly because you want the ideal size of the pupil to be formed, which will give the patient a very good quality of vision. So we repeat the same process superiorly with the 10-0 nylon, and we go ahead and form a pupil of the normal size. So this was the patient who was 1 month before the pupiloplasty, who had 6/6 vision but poor quality vision. He did not enjoy his quality of vision as much, and post the pupiloplasty, we're able to get the scar tissue not crossing through the pupillary area. So this gives the patient a very good quality as well as quantity of vision. Thank you.